foreigners. 77 are males and 28 are females. The youngest is 2, the oldest is 77. These cases are distributed in the following counties: Nairobi with 43, Busia with 18, Mombasa with 11, Turkana 7, Migori 6, Kwale and Kiambu 5 each, Kilifi, Machakos and Taita Taveta 3 cases each, Kisumu 2, Uasin Gishu, Siaya, Kajiado and Garissa 1 case each. By sub-counties, in Nairobi, the cases are from the following sub-counties: Ruaraka 14, Langata 5, Dagoretti North and Kamkunji 4 each, Embakasi West, Embakasi East and Kibra 3 cases each, Starehe and Westlands 2 cases each, Makadara, Mathare and Embakasi South 1 case each. In Busia, all the 18 cases are truck drivers at the Malaba border point. In Mombasa, the 11 cases are from Kisauni 5, Likoni 4, and Mvita 2. In Turkana, all 7 cases are of truck drivers at the Nadapal point of entry. In Migori, the 6 cases are from Kuria West 4, Nyatike and Suna East 1 each, while in Kiambu, the 5 cases are from Ruiru 2, Kiambu Town, Juja, and Lari 1 case each. In Kilifi, all the 3 cases are from Rabai. In Machakos, all the 3 cases are from Athi River, while in Taita Taveta, all the 3 cases are of truck drivers at Taveta border point. In Kisumu, the 2 cases again are of truck drivers in Kisumu Central, while in Uasin Gishu, the 1 case is also a truck driver in Tarbo. In Siaya, the 1 case is from Rarieda. In Garissa, the 1 case is from Dadaab. And in Kajiado, the 1 case is from Kajiado East. Of course, we now and then are saddened when we lose a patient. And today, we have lost another 1 patient to the disease, bringing the tally of deaths to 89. The patient was in Nairobi in one of the hospitals here. I send my heartfelt condolences to the family of the departed. As you will note, we are seeing more and more truck drivers turning positive, and the issue of truck drivers at the various border points, particularly the border points with the Uganda border at Busia and Malaba, have remained of great concern to us. And as a ministry, we are working very closely with the county government of Busia to provide them with the support and necessary support that they may need for us to jointly address the situation there. Fellow Kenyans, let me now say a few things about home-based isolation and care that we have talked about before. While the World Health Organization recommends that all laboratory-confirmed cases of COVID-19 be isolated and cared for in a healthcare facility, it also recognizes that not all cases can be cared for in a health facility when the numbers begin to rise, and that prioritization of hospitalization and alternate care systems need to be explored and considered. As you are aware, due to our rising numbers of COVID-19 cases, it is increasingly becoming untenable to isolate all patients in our health facilities for management and care. We are glad to inform you that today we are launching our home-based isolation and care guidelines for patients with COVID-19. This guideline is available on the Ministry of Health website, and I encourage you to look at it, download it, and look at it so to get a clear understanding of what it entails. This protocol has been developed to provide a solution in the management of the increasing numbers and the anticipated surge in COVID-19 cases. Currently, according to the available data that we have, 78% of infected persons, that is, positive cases, admitted in our hospitals are either asymptomatic or mildly symptomatic, and therefore can be managed at home, provided proper laid down procedures are followed. The home-based isolation and care guidelines dictates these procedures. The guidelines expound on key areas that include eligibility, care procedures, medical monitoring, referral system to health facilities when the need arises, criteria for determining recovery, and community participation, among others. The implementation of the guidelines shall be done under the supervision of medical and public health officials. Community health volunteers will be involved in the daily assessment of home-based patients and will be the key link between healthcare workers and the households. Home-based care in informal settlements, where households share small spaces, will require identification of institutions within the community, institutions that meet the recommendations for providing such care. And we are working on identifying such institutions within the community where such home-based care can be provided. And herein, we will also be drawing upon the Nyumba Kumi initiative in such settings, for they certainly have a role to play in supporting the care in the community. To succeed, the Ministry of Health appeals to non-governmental organizations, for they are very much involved and work at the community level, as well as others and well-wishers to partner with us in this fight against COVID-19. Implementation of these guidelines begins immediately. I therefore urge all stakeholders involved in the care of COVID-19 patients to adhere to these guidelines and ensure that it cascades to all informal caregivers of these patients in order to ensure delivery of quality services to our citizens. In conclusion, I want to restate that every effort be made to contain, stop, and reduce the transmission of the virus in our country at all costs. Thank you.
Thank you so much. My name is David Mudhoka from TV 47. My question touches on the truck drivers, especially at Busia, where the numbers are plummeting each day. What is the situation there? on matters, the quarantine facilities, isolation facilities? Is the county overwhelmed by the numbers? Thank you.
Thank you so much, Seth Olale, NTV. Just two quick ones. In terms of the number of health workers, is it directly proportional to the need at hand? That is the 78% of infected patients. Do we have capacity in terms of healthcare personnel? My second question is about the Lancet versus some of private hospitals in this country. We saw a variation in terms of test result for COVID patients who went to Lancet and the results differed from another in Nairobi hospital. As Ministry of Health, who is supposed to be the authority here? Thank you.
My name is Purity Muse from KBC. When you look at other nations, for instance, China or US, when the first case of corona was reported and 3 months on, then the countries were experiencing serious symptoms of coronavirus. But we are getting or almost hitting the 3rd month, and most cases, as you said, are asymptomatic. Is this the case, or do we expect the symptoms probably to be serious because most Kenyans are asymptomatic? Do we expect the symptoms to get serious, or this is the kind of COVID-19 that we have? And on the truck drivers, most numbers today were coming from truck drivers. Are they getting this virus locally or importing, getting from other countries? And what are you doing as a ministry, as the ministry, to stop this spread, especially infection among the truck drivers?
My name is Chomtai going from Citizen TV. When you've mentioned that you are starting the immediate implementation of the home-based care protocol, how many patients, if any, do you have under this program as you commence it? And maybe just expound on the fact that for those families that could not afford spaces that they can hold the patients that are there, what measures are you putting in place? And the second one, on truck drivers, there are protocols that you had outlined on where like truck drivers would have designated stops. Are you trying to manage those areas to ensure that they do not even spread to those particular areas that they are stopping in case of Namanga and Malaba and all the other areas?
Okay, yeah, thank you. David Mutoka, your question was regarding the truck drivers at Busia, the increasing numbers and whether we have capacity there to be able to manage them in quarantine or isolation. I think in my presentation I talked about that as being one of the challenges that we're facing in Busia, and health being a devolved system and the county being responsible for that function, we find it necessary that it's important that the national government works with the county to be able to boost its capacity to do this, particularly for those counties where on the border where there are corridors that go through them. We shall work very closely with those counties to build their capacity, and also to address this issue where we have, as I mentioned yesterday, the snarl up of trucks, because these themselves create a very high-risk situation which we do not want to have. So we are working with them. Perhaps when I give a chance to Dr. Kuria, he may talk a little bit more about the issue of truck drivers. Seth, you asked about whether we have the adequate capacity of health workers to cope with the number of cases that we are seeing. Now, you know what I said is that, and the whole idea about home-based care is because of the particular situation we are experiencing here. I think it was, this also will answer to Purity's question, where she asks about what we are observing here seems to be different from other places. We have said that when we pick up positive cases, anytime a person is confirmed to be positive by laboratory testing, That's what we call a confirmed or a positive case. Yes? Yeah, yeah. They are on that side, but I will try to face you. It's called a positive case. So that positive case, under normal circumstances, you will place that positive case in isolation. Well, what we are seeing is that 78% of the positive cases that we pick are actually asymptomatic, meaning they just do not display any symptoms, they do not appear to be sick, yet we know that they have a virus. And either asymptomatic or very mildly symptomatic, so that the symptoms may be just like something like a flu that you don't need to be hospitalized, you'll get over it in time. Given this observation that we have this kind of a number of patients who really do not need to be occupying a bed in a health facility, is the reason why we have looked at the possibility of home-based care. And these guidelines that we have talked about are able to ensure that if we put them in home-based care, we still are able to maintain and contain that person so that they do not spread the infection. That's what the guidelines are all about, to make sure that if you put them there in their homes or in a community setting, that you will still be able to eliminate the transmission of virus from that individual to others. So in a way, it is a good thing for us to do this, because then we will also, you do not need any specialized healthcare workers to take care of these individuals, because they can be taken care of within their homes by home carers, members of the family whom you can designate as home carers, who will be properly trained and equipped with the equipment and will follow those guidelines. It frees up our healthcare workers who will be required in facilities to take care of those who actually require more care. So in that sense, I think it is a positive thing. It will free up our healthcare workers. We can utilize those healthcare workers for some of the more serious cases that are required there, given that we already have a deficit in healthcare workers within our facilities, not only for COVID, but in general to provide medical care. Then the second question that you followed up with was this issue of what I would call the quality issue in testing. The issue of quality and ensuring that quality is maintained is a function of the ministry and our regulatory authorities. Quality of services is part of our function, and we are supposed to ensure that this quality is in place. As I had mentioned a couple of days ago, we have a protocol for determining the level of quality that the various laboratories provide. In fact, our approval of such facilities to be able to conduct these tests is based on a series of assessments of their capacity to be able to produce quality results repeatedly. So where such situations do arise, we will move in and we will administer the type of quality assurance tests that we do to make sure that the services being provided are of the right quality. The tests coming out of these facilities are the correct tests. So we do address this, and we are addressing any discordances that we see. At the same time, recognizing the complexities of the particular test that we're working with in conditions where they can fail or produce a false positive or a false negative result. But the determination will be made by the ministry, and corrective measures those institutions will be required to put in the right corrective measures in order to continue to enjoy the approval that they have from the ministry to conduct these tests. Purity of KBC, I think I have answered that part on the kind of trajectory we are seeing largely in Africa, where a good number of our patients are asymptomatic. It is an observation, and which is slightly different from what has been seen in other countries. In those countries that you mentioned, you can see that within about 2 months or so of their first cases, they were really hitting very large numbers of people who required critical care, and their systems were overwhelmed. Now, whether we are still at a low level of our curve, and we may reach that curve, we cannot say for sure right now. We'll just have to wait and see. But we do hope that this pattern is a different pattern that is not, as demanding in terms of care than what we have seen in other countries. It's also dangerous to live in a comfort of something that you don't know how it will turn out. So we do not want to take any chances and think that because we are seeing this, that we are safe, in a better place than others. No, we do not know where we are on this curve. Tomorrow there could be a huge surge. And by the way, we have seen, and cases have been seen where people are asymptomatic, but they can very quickly progress into serious clinical conditions. Such cases have been recorded. So we need to be prepared for the worst. And I think that's the approach that we are taking. You asked also about the truck drivers, that we are seeing increasing numbers of positive cases among truck drivers. I think your question was, are these truck drivers importing this from other places, or is it local transmission? Well, I think if you look at our truck drivers that may be coming from, who are going out of the country, say on the northern corridor, from Mombasa, Nairobi, taking their cargo across and then being found positive at the border, I would say that that is probably local transmission within the country, because they are within the country wanting to move out. But when we do get drivers who are coming into the country from another country, in that case, we can say that those, if they turn out positive, those are likely to be imported cases. And of course, we don't allow. At any rate, if we are able to determine at the border point, for example, at Namanga, where we have the functional lab there, when we test drivers, whether Kenyan or Tanzanian who are coming into the country, if they turn out positive, then we do not allow the foreign drivers to come in. But of course, the Kenyan drivers will come in and will be given the right kind of treatment, that is isolation, will be placed in isolation. So largely, I mean, now we have the virus in our neighboring countries. The virus is circulating in Tanzania, it is circulating in Uganda, it is circulating in Somalia. So, if you look at it as a region, it's there. So we have transmission within the region, so to speak. Okay. Chemtai, how many patients are asymptomatic, and how many patients are we going to put into this program of home-based care? As I said again, because of the nature of infections we see being asymptomatic, I think, of course, priority will be to take those who are lowest risk into home-based care if those criteria that are laid out in the home-based care guidelines are met. And it will be on a case-by-case basis that will be determined, because when you look at the guidelines, you will see what is required. The facility where, the household where the patient will be kept will need to be looked at, and the measures that are required will have to be in place. So it will be done on a case-by-case basis. In terms of those where, say, we talked about community-based facility, where we can place some of these asymptomatic patients within the community, but in a facility where they can be cared for and observed. That I would imagine those who cannot pay from the informal settlements, when we do identify these institutions and set them up, I think it would be an obligation of the state to be able to meet those costs of keeping them there. I think that was it. And
My name is Graham Kajilo from The Standard. My question is related to a study that was published by Harvard University that claimed that the virus was already circulating in China before the first case was reported in December. In our Kenyan context, that we've seen a lot of community infection, I would like to find out to what extent have you done the surveillance of the disease in the country in order for us to, probably to justify that the disease was already here before the first case was discovered in March 12th.
Na waziri, naitwa Haemba kutoka Ebru. Naomba tu kujua mataifa ambayo yameweza kukumbatia mfumo wa wagonjwa wa virusi vya corona kuweza kutibiwa nyumbani, mataifa ni mangapi na ni yapi hasa? Alafu labda katika Afrika, je, ni Kenya ambayo itakuwa labda taifa la kwanza? Alafu swala lingine ni kuhusiana na vyeti na barua zinazo
taifa la kwanza kufanya nini?
Labda kujiunga barani Afrika, labda Kenya itakuwa ya kwanza labda kukumbatia mfumo huu wa wagonjwa wa COVID-19 kutibiwa nyumbani. Alafu swala lingine ni barua na vyeti vinavyotolewa kwa madereva na hata wananchi wengine wanaovuka labda nje ya Nairobi na hata Mombasa. Wengi inadaiwa kwamba baadhi ya barua hizo ni gushi. Je, labda kama serikali labda maafisa wa polisi katika mipaka watajua vipi ya kwamba hiki cheti ni halali?
Jimmy Mbogo from K24. Now, a couple of questions. Number one, with regards to the active cases that are currently in hospital, how many do we have that are in critical condition, and do they have underlying medical condition, or what is the pattern that you're currently seeing? And the other issue is with regards to the border points. We understand that there's a system failure from the Ugandan side. Are you working with your partners, for instance, the Ministry of Transport, to sort of clear this or to understand what are the other issues? And lastly, just a follow-up with regards to the budget being read tomorrow. We understand that the ministry is likely to get over 100 billion shillings coming in to be able to help in this fight. We've seen a lot of money being taken to counties, yet the medical facilities in counties still remain in deplorable condition. What are you doing to follow up with counties and ensuring that this money that is being given to them is directed or channeled to those medical facilities?
Okay, thank you. I'll tackle some of those questions. Others, I think I will have my colleagues here handle it. There was a question regarding the virus. You talked about a publication. I didn't catch which publication, but I think I got the essence of your question was really, can we tell whether this virus was already with us before the first case on the 13th of March? My answer to that would be, if you look at the origin of this initially epidemic, which became a pandemic, we all know that where it started, and we know how it spread quickly to many other places. And the timeline that we know of, this thing began in China in around December, for the whole month of December. It was towards the end of December, in January, that the world became aware and WHO became aware of this virus. And a month is a long time in terms of the global nature of things these days, particularly in terms of travel, where people could have easily traveled to different places in this world, people who are potentially infected and spread it. The way to be able to determine that kind of tracing back, there are ways of doing that. One is doing genetic studies by looking at the viruses that are circulating in a particular country. You can look at the sequences of those viruses, and then you can be able to relate these isolates, to the sequences of isolates in other places. So if you find that there are isolates that were circulating, for example, in Wuhan during that time that the virus, the pandemic broke out, and you're able to relate to some that may be present in your own area and community, there are methodologies that you can use to be able to develop relationships or what is called genetic trees that might be able to answer this question. And we do know that our Kenya Medical Research Institute has actually been doing part of this work at Kilifi. Let's wait and see. As the body of this work increases, we may be able to get an answer about when this virus might actually have come into the country, okay? If that was the case. Home-based care. Will we be the first country that is implementing